Medtronic technologies impacted more than 72 million people in the last year, equating to 2 people every second. Harnessing the power of technology to take healthcare further, each technology has unique benefits designed to serve patients. The goal of this program is to get closer to the patient and delve into the challenges and impact of each technology in practice. This is the Medtronic MedEd Learning Experience. No monitoring system should be used as the sole basis for diagnosis or therapy, and they are intended as an adjunct in patient assessment. Reliance on a single monitoring system alone for patient management is not recommended. The contents and conclusions of the following programs are solely those of the speakers unless otherwise cited. The speakers are responsible for all content and any necessary permissions. The speakers receive funding from Covidian LP, a Medtronic company, for this speaking engagement. Medtronic's medical education programs are offered to provide attendees education on FDA-cleared indications and use of our products when applicable. For this segment of the series, a discussion on patient safety in procedural sedation. Can you show some case studies? To help answer this question are procedural sedation nurse Linda Erfle, CRNA Brian Berry, and gastroenterologist Dr. Ashish Chawla.
So it's going to be a 68-year-old white female, hypertension CAD on Plavix, comes in, BMI is 35, comes in with a positive FIT test, which is fecal immunohistochemical test, no prior EGD or colon and no family history. Report she's got pretty severe chronic constipation and has had some surgeries. Hysterectomy, which makes colonoscopy difficult, appendectomy and a cholecystectomy. Allergies are just a Cipro, and the social and family history is unrevealing. Exam, other than mild hypertension and a little aortic sclerosis murmur, is otherwise normal. So we book her in for a 2-day prep, given her chronic constipation, and bring her in for a colonoscopy. On the day of the procedure, vital signs are all good. We start colonoscopy sedation. And in this case, I'm working with a CRNA, no CRNA, excuse me, but a RN who's giving sedation. And we start with 2 milligrams of IV Versed and fentanyl 50 micrograms. The patient slowly becomes drowsy. We give another one of Versed, and they kind of reach what we call moderate sedation. Start the procedure, lots of redundant colon. We finally get there, remove 2 cecal polyps, and then on the way back, we see a large polyp. It looks kind of flat and spreading, and we really think we need to lift it with some saline and then take it off. As we're setting up for this, the nurse notices, the patient's getting quite agitated. I look at the vital signs at that time, and the blood pressure is 172/88. It's 100% on 2 liters. I say, well, the patient's clearly moving. We give another one of Versed, and basically between 35 seconds to 50 seconds later, she is apneic. I notice that the O2 sats dropped to 60%. We do a chin thrust. She takes a breath in, and then we start bag mask ventilation because we need to get her O2 sat up. After 20 seconds of this, she's clearly 100%, but now her heart rate is 128 and her blood pressure is 100/50. We wait and watch. She doesn't really get much better. So we decide, okay, we're going to abort the procedure because this is an outpatient procedural sedation unit. We'll watch her. And sure enough, an hour in the PACU with some volume and oxygen, she's totally awake, pain-free, and she says to me, did I complete the procedure? And it's then I have to explain to her that I didn't really finish it. And I say to you, Brian, what really happened during this procedure? And what do you think about capnography?
Dr. Chawla, that's a great clinical situation case study of a classic example. You and I have talked about this many, many times, how a respiratory event totally derails the day. We had to resort to bag mask ventilation. What does that do? That delays your procedure 30 minutes, maybe if it's a real difficult one, an hour. What does that do? That delays the whole day. Then what do we see? We see everyone on overtime. We see everyone, the the morale takes a hit. So the staff satisfaction takes a hit. The gastroenterologist or the proceduralist morale takes a hit, and patient satisfaction declines because you got patients waiting longer. So that's one factor of what we just heard from you. And there's a psychological component to this as well, because you're thinking about that case that you had to bag mask in on the next case, and it's just human nature that's going to occur most likely. So you asked at the very end, you said, what about capnography? Well, capnography can prevent what we just talked about. I mean, it would have detected the respiratory compromised event, and hopefully you could have done something very easy, a jaw thrust, chin lift, and prevented that full-on decline of that patient and recognized apnea or a decline or obstruction in the patient's breath the instant it occurred.
And sadly, now she's got to come back for another procedure.
Yeah, that was her biggest complaint because, we didn't catch the respiratory depression early enough. And she ended up with an incomplete procedure. And as you know, Linda, we often see other complications during these procedures.
Absolutely. I mean, we see people retching, aspirating, they have to go to the ER, they have to get x-rays, they turn into pneumonia. But most importantly, is she going to come back and have it again? And when the complications happen, they don't want to come back.
And to be honest with you, this happened right during COVID or right before COVID. So it took the patient 3.5 years to come back.
Oh.
So it did lead to a delay in care. And I honestly wanted to present this case, what I call a near miss. I didn't want to present an actual complication because we often say, well, they don't happen to us or they happen infrequently. But I think these near misses, first of all, that part is not true. But I also think that near misses happen routinely and we don't think twice about it. I liken this comparing our patient safety to what airline safety is. We all know flying in an airplane is the safest way to travel. Yet, if there is one airplane or airline accident, we know it hits the news in every single newspaper and every single national television center. It impacts how people view airline travel. Therefore, the airline industry and the FAA have integrated multiple ways, including flight controllers to high intensity, high definition radars to basically help improve patient safety. And I think this is one of the times where if we had a simple thing like capnography, we would have realized that the patient was likely agitated, likely was moving around because the patient was hypercarbic at the time. The patient wasn't breathing for probably a minute or a minute and a half before we recognized it. She had an obstruction. We instead gave her another 1 milligram of Versed, and we worsened the problem. And this led to what I call a near miss. Again, if we want to treat our patients like they're our family, we have to prevent near misses and absolutely have to prevent adverse events, or at least reduce adverse events to as much possible by integrating technology like capnography.
Please tune in next week for a new segment from this series wherever you find your podcast. This is the Medtronic MedEd Learning Experience. Thank you for listening.